Good afternoon. It's Dr. Dale Bratzler. I'm the University Chief COVID Officer and the Chief Quality Officer for OU Medicine. I want to give you a quick update of where we're at in the state with respect to COVID-19, and then I wanted this week to highlight a few of the interesting studies that came out this week that I think people should be aware of. So as of this morning, we now have 62,040 confirmed cases of COVID-19 in the state. 846 Oklahomans have lost their life. And if you just look at the past week, we've had 5,780 students that have tested positive and 60 deaths this past week. Sadly, I wish I could report otherwise, but we're seeing a slow increase in the 7-day rolling average of new cases. As of this morning, we hit 826 new cases on average daily in Oklahoma. So for the past 2 weeks now, we've seen a slow but steady increase in the trend of new cases in the state. Tulsa and Oklahoma County have exactly the same number of confirmed cases since the onset of the pandemic now, but we've seen some upticks both in Payne County and in Cleveland County, where we have our two largest college campuses in the state. And if you look at the past week in terms of testing, just over 11% of all of the tests that have been run this past week have been positive. That's a bit higher than we were the past 2 weeks, but we've seen substantial increase in the number of tests that are being done that are actually coming out positive. Hospitalizations, I think the one positive trend that we've seen this past week is that hospitalizations are down. We've seen a steady decline in the number of people in the hospital. There were 518 people in the hospital yesterday. Of those with a confirmed case, 447 cases and 193 people that were in intensive care unit beds yesterday in the state. A couple of the things I wanted to highlight, though. Why are hospitalizations going down? One of the interesting things that we've seen in the data is that the age group now that accounts for the most new cases on an average weekly basis in Oklahoma are the 15 to 24-year-old age group. So it's the high school, college age group that are now more commonly testing positive and become the largest group that are testing positive new cases in the state. And of course, those people in that age group typically don't get as sick. They're less likely to be hospitalized, and we see fewer obviously severe complications in that age group. So that may be accounting for some of the decline in the total number of hospitalizations in the state. Before I quit, with my prepared comments, I just want to highlight a couple of studies that were published this past week that I think are really important. The first, there was a series of articles that were published on September 2nd in the Journal of the American Medical Association that gave us some really good news about the use of corticosteroids, the steroid medications that are common, that are widely available to prevent or to reduce the death rate from COVID-19. So a large study was published that looked at multiple different studies that had been done using corticosteroids and found two important things. Number one, if you looked at the 28-day death rate from COVID-19, and again, the patients that were enrolled in these studies were all patients who were critically ill, seriously ill, there was a 34% reduction in the mortality rate. The other important thing from this study was they found that it was consistent across multiple different types of corticosteroids. These are medications that U.S. hospitals have and have had for a long time. We use them routinely for other conditions. They're not in short supply. They're readily available and they're inexpensive. So we now have really good news that one of the new treatments that we identified a few weeks ago out of studies using drugs like dexamethasone or drugs like hydrocortisone can reduce mortality from COVID-19. So that's really exciting. That will help us continue to reduce the death rate of patients who are critically ill with COVID-19. Another important study that was published this past week looked at COVID in patients who are pregnant. And as you might expect, patients with who are pregnant who develop COVID-19 actually do have worse outcomes, are more likely to be in the hospital, have premature births and other complications. So again, pregnancy is a group of patients that we want to try to avoid getting this infection because there is some risk to them and their baby with COVID-19. Finally, there have been a lot of questions this week about how vaccines will be distributed once they're available. I know that health departments have been told to start preparing for a vaccine that might be available in November. Honestly, at this point, I don't know if that's feasible because even when one of the vaccine companies gets their vaccine approved, possibly through emergency use authorization from the Food and Drug Administration, they're still going to have to ramp up some of the production capability to actually get the vaccine out there for use. And so it's unclear to me how quickly they'll be able to ramp that up and actually distribute the vaccine to get it on the front lines. But the handout that I'm sending out today has an interesting paper that comes from the National Academy of Sciences that pulled together a expert group to start thinking about how we prioritize who gets the vaccine. And I won't go through details of their discussion, but as you might expect, they recommended that the first people that might be vaccinated would be frontline, first-line responders. So paramedics, firefighters, doctors, nurses in emergency rooms, ICUs, those people who are very closely in the face of patients with COVID-19 who would be at substantial risk. Then the next group might be those people who have severe complications, underlying illnesses that put them at risk of the complications of COVID-19. So that might include immunosuppressed patients, cancer patients, patients with diabetes, heart disease, lung disease, because we know that they're more likely to get infected, and when they get infected, they are often much sicker than patients who do not get COVID-19. So it's a nice article about prioritization of how vaccine might be distributed. Finally, there is one last, there's one more paper that I actually highlighted this week, and it's about kids and COVID. And again, just to highlight, kids do get this infection, and they're often asymptomatic, and they do have a lot of virus, and they can shed virus for a long time. So again, I think there's increasing concern that kids, young kids, who really don't get sick with the disease but can get infected, could spread the virus to older people who may have more serious complications. So just another paper that's supported that kids do get COVID-19 and can potentially serve as spreaders of the disease. So I'll stop there and see what questions there are today.
Okay. You mentioned the vaccine rolling out possibly November or December. And you answered already, I think, does that make sense, or is it very ambitious? But what problems would you or do you foresee with the vaccine rollout?
Well, so I think there are a number of problems with vaccine rollout that are just simply going to have to be addressed. One is the prioritization. How do you prioritize it? How do you get it to the people who are most likely to benefit from the vaccine? I think we all would agree that paramedics or firefighters or other people who are on the front line that have that first contact with a person that may or may not be infected might be a high priority. Certainly the nurses that work in emergency rooms or in intensive care units, and of course the doctors. What about the staff that work in nursing homes? Because we know that if healthcare workers in nursing homes get infected, then they may do well, but the residents of the nursing home won't. So how do we prioritize the vaccine? I think that's going to be really important, and it's an important question for us to answer as a society because we need to vaccinate those people who have the greatest risk. I think all of us in public health have some concerns about the rapidity of development, and we just want to make sure that before any vaccine is released, before it receives emergency use authorization from the FDA or full approval by the FDA, that it's been fully vetted, that it works and it's safe. And so I think there's been a lot of concern that we don't forego the processes that we would use for any other vaccine or frankly for any other medication, just to make sure that we have it delivered and that it's a safe vaccine and that it's been proven to be efficacious.
You also mentioned the study from the National Academies of Science that you're sending out in the handout. And you answered the first part of this about what would that look like. But in Oklahoma, as a follow-up, which groups would likely get that first?
So again, I think, almost every single study or discussion of this I've seen would prioritize first responders or healthcare providers that are directly taking care of infected patients. We know that there are particular risks. Even in Oklahoma, there's a higher proportion of healthcare workers who've been infected again. And when I say healthcare workers, I'm also including first responders that may be placed in harm's way because of the work that they do. So paramedics and others that are the first to see patients. And then again, those people who are at particular risk of the complications, the sick, the elderly, those that have diseases that put them at risk of death from this disease. We know in Oklahoma, for instance, that almost 80% of the deaths from COVID-19 are in patients who are 65 years of age and older. So that may be a group that gets prioritized for vaccination.
The state is changing the way it's reporting numbers next week, and it will include antigen tests. It's also moving to the Johns Hopkins method for reporting positivity rate. Are these good moves, and how do you think that will change the numbers?
Yeah, absolutely. So I applaud the state health department in making that change. We've been calling for it for some time. We know that a lot of people do go to an urgent care center or another place that's doing rapid antigen testing. And when those rapid antigen tests come back positive, that person has COVID-19. And I know the health department has been following up with some of those patients by use of contact tracing and other things. But I think one of the big concerns that we've had is that they're not getting counted in the daily case numbers, and that makes it harder to know the impact and spread of the disease in your local community. So because so many people do get a rapid antigen test and because they're fairly readily available, I think it's important that we make sure that we're counting those cases. Again, I don't know exactly the methodology behind the Hopkins positivity, but again, reporting the percentage of tests that are positive is very, very important, because for me it's an early warning sign that we may see an uptick in the number of cases in our state.
Are the numbers high enough to consider moving all courses online for OU students?
Well, so there's a large group of people on the Norman campus that include the leadership all the way up to the president, the provost, a number of the deans, myself and others, who look at all of the numbers on the Norman campus daily. Realize on the Norman campus we have 38,000 students, staff, and faculty. We're a large community within another community, the city of Norman. And so, although there's been an uptick in the number of cases in which we expected, and we're isolating and keeping those people quarantined from others on campus, we also know that it's a very small proportion of the total student body, staff, and faculty body on the campus. So we're watching the numbers very carefully. We created a dashboard that's online that shows the number of positive cases, how many people are testing positive, how many cases we're seeing in Norman, Cleveland County. We're tracking the zip codes immediately around the campus to watch that very carefully. And then we will make decisions about whether we close, move to online, perhaps move some courses online and not move others online, depending on the type of course it is, whether it includes laboratory or other things. But the one thing we're trying to avoid is just shutting down the entire campus. We think we can be a bit more strategic about it if we need to do so. If we need to do so, we will.
Will the university implement a one test per week requirement for the OU community, and if not, why?
Well, at this time, there are no plans to implement a one test per week. Again, we have 38,000 people. In the state of Oklahoma, we only do about 50,000 tests per week, maybe 60. So just the logistics of testing 38,000 people once a week would be incredibly both difficult. Operationally, it would be very difficult. There is no lab that I'm aware of in the state that has the capacity to do 38,000 additional tests per week. And also, obviously, testing, whether we like it or not, is still very expensive. And you could literally see spending millions and millions of dollars per week doing tests if you were doing them at that frequency. That said, we are trying to do very specifically some targeted testing to help us look at what's happening on the Norman campus. So we're testing sewage, and we're now testing sewage from all of the buildings on campus so we can see if there are any defined hotspots or potentially any areas where there may be outbreaks. Secondly, we have free testing at the Goddard Health Center. Any student, staff, faculty who has concerns, symptoms, has history of a contact, or just feels like they need to be tested can go to the Goddard Health Center and get a test. This week, in fact, we just opened a voluntary testing site on campus, and we're specifically targeting those students that live in the university housing and encouraging them to come and get a test done. We could do potentially up to 500 tests per day is about the capacity of the lab to do additional testing. But we can do 500 more, so that would take us up to around 700 a day on that particular campus, but it doesn't get us anywhere near 38,000 tests that it would take to test all students, staff, and faculty once a week. We just don't have that capacity.
And of course, this is Labor Day weekend. So what can people do to stay safe during Labor Day weekend travel?
Well, so I've had several press conferences this week where we've talked about Labor Day. Again, it's the rules that we're all aware of. Try to avoid crowds, particularly if you're around a crowd where people are not wearing masks. Please avoid that circumstance. Wear a mask. Do physical distancing as much as you can. Enhanced hand hygiene. If you're traveling, certainly most people probably would be very, very careful about recommending any travel where you're in a group vehicle with a bunch of people. If it's your family, we still encourage people to wear masks just to reduce transmission of the disease. Remember, the other thing about transmission is that home is one of the most common places that people get the infection from someone else. So the scenario is a family of 4, maybe the father gets infected at work, comes home. Of course, we don't wear a mask at home around our immediate family, and then we spread it to somebody else within our family. So if you're bringing groups of family together for outings over the Labor Day weekend, perhaps for a barbecue or something like that, just remember that when you get people together in close proximity without masks, you increase the risk of transmission because as we've talked about many, many times before, 40 to 45% of the people who get this infection have no symptoms. And those people could be infected and could spread the virus to somebody else who's not infected. So as I tell all of my students and others, just assume anybody you're around could be infected and take precautions.
And the last question we have today, and I'm not sure that Oklahoma still does this, but how are state-required quarantines for travelers enforced?
So I don't know if we still have any existing state-required quarantines in place. We did have early during the pandemic, I know the governor had issued some executive orders, but I think most of those have expired at this point. I think the bigger issue for Oklahomans right now is if you're traveling to other states, some of those states do have required periods of isolation of 14 days if you go to that state before you can go out into public. So I'm not aware of any explicit state required quarantines that are still in force in Oklahoma, but honestly, I don't know. I've been told that most of the governor's original executive actions have actually expired now. So the University of Oklahoma, we're still trying to restrict travel as much as possible, though we do allow travel for essential research and other things where the dean and the provost of the college have actually approved it.
Very good. That's all we have for today.